Anticoagulants are used to treat and prevent blood clots that may occur in your blood vessels, whether it be an artery or a vein. Blood supply and oxygen supply are reduced by the result of a blocked artery, which then leads to a stroke or heart attack and eventually death. Talk about oral anticoagulants. The first drug that comes to mind is warfarin. Discovered in the 1920s, warfarin was originally used in order to treat internal bleeding in cattle and sheep. Only until recently, vitamin K antagonists have been the only anticoagulants available. In the new era, few bioavailability and pharmacokinetics in drug interactions are suitable for daily dosing. Recently, there are new oral anticoagulants that have been recently approved by the Australian Therapeutics Goods Administration, TGA. Rivaroxaban and dabigatran are some of the new anticoagulants that are available in the Australian market. Warfarin and the newer anticoagulants acts on the coagulation cascade, however have different targets. Warfarin reduces the production of fibrin by inhibiting vitamin K epoxide reductase, which includes factors 2, 7, 9, and 10, and anticoagulant proteins C and F. Rivaroxaban or Xarelto, however, directly inhibits factor 10A. It is the first oral anticoagulant to specifically target factor 10A for a number of reasons. It occupies the crossroads between the intrinsic and extrinsic pathways and is accountable for converting prothrombin to thrombin. It inhibits 3 prothrombinase-associated and clot-associated factor 10A without affecting platelet aggregation. Another recently approved drug by TGA, dabigatran etexylate, is a prodrug in which after oral absorption converts into its active form called dabigatran or Pradaxa in the liver by esterase catalyzed hydrolysis. It is a direct thrombin inhibitor, which means that the drug prevents the conversion of fibrinogen to fibrin and prevents thrombus formation. So let's compare warfarin and the new drugs by looking at its advantages and disadvantages. Warfarin prevents arterial and venous thrombosis, which helps reduce strokes and heart attacks. Since it is mostly widely used anticoagulant globally, there is plenty of experience in its clinical use. It can be readily reversible with fresh frozen plasma and vitamin K. Warfarin has a long half-life of approximately 40 hours. Patients only need a daily dose of warfarin, and there are antidotes available. However, routine monitoring and regular blood tests are required to maintain the international normalized ratio in order to keep within the therapeutic range. It interacts with other medications along with alcohol and certain foods, especially those that contain high vitamin K. A narrow therapeutic window and delayed onset and offset of action, drug-to-drug interactions due to high binding rate to plasma proteins and metabolism via CYP450. There is a major risk of bleeding, which can cause significant morbidity and mortality. Should be avoided during pregnancy, as there is a risk in fetal bleeding throughout pregnancy. The risk for death rate after trauma is significantly higher in patients using warfarin, and development of dependence for the drug. New oral anticoagulants advantages include there is a rapid onset and offset of action, a wide therapeutic window, administered orally. They lower the risk of intracranial bleeding and incidence of major bleeding. There is no need for regular laboratory monitoring, low drug-to-drug interaction, and low potential for food, so there is no dietary restrictions. Yet, they are non-reversible agents, have a short half-life. Since they are still relatively new, there is a lack of long-term use in warfarin. There is a lack of antidotes and procedures that can be used in emergencies such as hemorrhage or an overdose. Women who are breastfeeding should not be prescribed with new oral anticoagulants. Same dosage must be consumed twice a day, and they are costly. Warfarin has its limitations, which includes its slow onset of action, which means it must be overlapped with heparin, and its activity must be constantly monitored as its dosing is variable due to the influence of vitamin K and genetic polymorphisms in enzymes and drug-to-drug interactions that encourage or limit their activity. This also makes it inconvenient and costly for patients. Although new anticoagulants build on a better understanding on coagulation pathways, there are also potential limitations, including drug level for safe major surgery is unidentified, so an expertise such as a hematologist needs to be consulted. Patients may have difficulty keeping up with a twice-daily dosage schedule, so if a dose is missed, it may increase the risk of an embolism. Even though warfarin continues to be one of the most common anticoagulants used worldwide, its several disadvantages do not make it an ideal option. However, warfarin has a longer duration and it could be overlapped with new anticoagulants or heparin to treat thrombosis. Based on current available research of new anticoagulants, there are still too many unknowns. However, it does offer promising results for those with atrial fibrillation. Further clinical research and experience of its use in real-world situations is essential to see if these new drugs are a better option than vitamin K antagonists. Until further research is made, the correct choice of drugs should be based on their patient. Will warfarin be replaced by these new anticoagulants?